to the third and final lecture of this year's Ihaka series. My name is Ben Stevenson. I'm a member of the Department of Statistics here, and today it is my great pleasure to be introducing our speaker, Dr. Rachelle Binny. Rachelle is originally from Fife in Scotland. She did her undergraduate degree in mathematical biology at the University of Dundee, but was then tempted to the shores of Aotearoa for her PhD. She attended the University of Canterbury, where she investigated models for cell movement and cell populations. She made important advancements, for example, in a transition from mathematical deterministic models, which might be fitted in, say, MATLAB, towards stochastic models, which might be fitted in R. And as attendees at an Ihaka lecture, I'm sure you'll agree with me, that sounds like a good thing. Following her PhD, she picked up a postdoctoral research role at Manaaki Whenua-Landcare research. One of her research areas following that has been modeling a different kind of movement, not the movement of cells and cell populations, but the movement of animals and wildlife populations. Her first role at Manaaki Whenua-Landcare research was a postdoc. The way Rachelle described it to me was that the job involved fitting a bunch of models to a data set, and it was a 2-year role. And 3 years later, she was still cleaning the data. And I'm sure all the applied statisticians in the room know that feeling all too well. I know she was just being modest because she wasn't just cleaning data for 2 or 3 years, because she has a raft of publications in the field of ecological statistics to show for it. 2020 brought change and new challenges to all of us as we adapted to life in a pandemic. And for Rachelle, it brought change and new challenges to her research program because she was recruited to a team of scientists tasked with understanding and investigating the spread of COVID-19. This meant that Rachelle was investigating models for a third kind of movement, not the movement of cells, not the movement of animals, but of course the movement of a virus through our population. And that's the topic of her lecture today. This is actually a very fitting day for this event. I'm not sure if many of you remember what you were doing exactly 1 year ago on the 12th of August 2020, but today is the 1-year anniversary of Auckland being thrown into a new lockdown, which ultimately lasted until the 7th of October, until we returned to Alert Level 1. So I'm very thankful that we are here holding this event in person, and I'm very much looking forward to hearing about the role that mathematics and statistics has played in combating COVID-19 in this country. So please join me in welcoming today's speaker. Thank you very much, Dr. Rachelle Binny.
Tēnā koutou katoa. Thanks, Ben, for the really warm introduction there. It feels very special to be in the same room with the audience today. It's not been like that for the last 18 months for many of us having to switch to online. Believe me, the irony of my talk on modelling for the COVID response having to be delayed because of COVID was not lost on me at all. And as Ben's just said, it's really been quite a whirlwind of a year over the last 18 months or so. If you'd asked me back in January last year, would I be standing up here in front of you all talking about modelling COVID, I think I would have just laughed. It's really been quite a whirlwind and lots of new experiences along the way, some of which I'll share with you today. But it's really been quite an interesting experience, and the work I'll talk about today isn't just work that I've been involved in, it's really been a very collaborative team effort. Here are the names of the team that I've been working most closely with. So alongside myself, we've had Alex, James and Michael Plank, who are based down at the University of Canterbury. They're mathematical biologists down there. They were co-leaders on this team that I've been involved in. Professor Sean Hendy, who many of you will know from Uni of Auckland. Sean's the past director of Te Pūnaha Matatini, the Centre of Research Excellence for Complex Systems. And he's also leading the COVID research programme for GPM. Also on the team, we had Nick Stein and Canon Ridings, who you might also know from Uni of Auckland, and Audrey Lustig, who's a colleague with me at Manaaki Whenua. So this really has been a very collaborative effort. And it might be a bit of a puzzle as to why somebody who's currently working in more of a mathematical and statistical ecology space has been doing COVID modelling. But actually, the type of modelling I do at Manaaki Whenua is looking at the spread of invasive pest species, not pests as in viruses, but pests as in invasive mammals. And we also do some modelling for wildlife disease. So there are actually a lot of insights that I get in my day-to-day job, pre-COVID, that have been quite useful in understanding how this virus might spread. And I've just put some examples up here. So frequently we're having to develop and simulate models to explain how pest populations grow and spread through New Zealand. And also for wildlife disease, how the dynamics of hosts and pathogens unfold over space and time. We're also interested in what kind of management interventions might be useful for controlling those pests or the spread of wildlife disease. So you can start to see maybe some possible connections with how, say, alert levels in New Zealand might be affecting the spread of the virus. And then once pests are potentially eradicated, managers need to go in and do surveillance. So we do a lot of modelling around trying to detect pests that may still be present at particular sites after elimination. We often want to predict how likely it is that we've eradicated a threat. And once we have eliminated it, we're then interested in trying to prevent it reinvading, coming through a border, say, and we want to detect any reincursions that do occur as early as possible so we can deal with them before they become too big a problem. So quite a different system, but a few crossovers that have been quite useful when we started to think about COVID this year. And just a bit of background about Te Pūnaha Matatini. So I'm also, my other hat is that I'm an investigator with Te Pūnaha Matatini. We were established back in 2015 with a group of about 70 investigators. And we all have quite a broad range of expertise in different disciplines. And that's one of the beautiful things is we get together to solve problems that are very complex, and we bring all these different views and skills to the table. But ultimately, we're all about doing data modelling, and we work on social systems, economic systems, and ecological systems, and often the combinations of 2 or even 3 of those different types of problems. And we've also worked on disease as well. So we were involved in doing some modelling around M. bovis and seasonal flu, and also the Havelock North gastroenteritis outbreak. And to do that, we had to get some practice working with different types of data, and we also had to build relationships with policymakers and decision makers so that ultimately that modelling was going to be useful. So I'll introduce you to the wider team, the group that I've been working most closely with, whose names were up on the first slide are shown here on the right. We're affectionately known as the Stochastic branching process team. And that's the model I'll mainly be talking about today. But this is just one component of a much wider program of COVID research that's been taking place. So we've got also a sub-team who's looking at building, or they've built a contagion network model. So this is one that models every single New Zealander in the country and looks at how they interact in the different places they would encounter. So at home, their place of work, the places they go to school, and models the spread of a disease through those networks. We've also got a subgroup who are called the Counting and Countering the Infodemic. And they're really interested in the misinformation and the disinformation that's been arising throughout the pandemic and trying to track and understand why that misinformation spreads. Earlier on in the course of the pandemic, there were also some researchers based at Manaaki Whenua who were interested in some of the social science questions around COVID. So things like how does behaviour and attitudes, how did that change through the lockdowns and afterwards? So, how willing were people to wear masks, for example? How willing were they to comply with lockdown restrictions? We had teams working on hospitalisation, so they were working quite closely with district health boards to help them with their planning, trying to predict if there was a big outbreak, how many hospitalisations could we expect to see. A phylogenomics team who are really interested in building computational tools to look at the genomics data from New Zealand. And we also have a number of panels as well, so panels for peer review, for ethics, equity, and at-risk communities. So it's a very wide-ranging program of research, and I'll really just be talking about the stochastic branching process team today. So I'm going to take you on a bit of a road trip back to near the start of last year. And rather than delve into kind of any one component of the model, the modelling that we did, I'm going to try and give you a bit of an overview of at least most of last year. We'll see how we go. And really just try and cover some of the kind of landmark modelling moments, at least from my perspective. So back in February 2020, this is when everything kind of kicked off at the start, and we were starting to look at the news that was unfolding in Wuhan in China, and we could see that there was this emerging new virus that we didn't know much about, but that seemed to be spreading very rapidly and was starting to become quite scary. And then over the course of January and February, we watched as international travellers spread the virus from Wuhan to other parts of the world, and we saw outbreaks start to appear in Europe and the States. And for a lot of governments, these cases and outbreaks were being sparked before they'd really had any time to think carefully about how they might prepare for a potential epidemic in their country. In New Zealand, we had a little bit more time to watch what was unfolding around the world, but very quickly it was becoming apparent that it was going to arrive in New Zealand. It was only a matter of time, and we had to think quite carefully about how we were going to prepare for this. And then towards the end of the month, 28th of February, it happened. We got our first COVID case in New Zealand in an individual who was returning from overseas travel. And things really ramped up then, and there were a lot of questions being asked, but still really very little information about this virus, about how it spreads, who it might target, and how we might control it. But it's exactly in this kind of situation where we potentially don't have very much information, but we have lots of questions that modelling can be really useful. So what we usually would attempt to do in these kind of situations is to build a model with what information we do have, simulate a range of scenarios and start to compare outcomes for those different scenarios. And then as we do learn more about the system that we're dealing with, we can, over time, refine our model, adapt it, and improve it. And this is quite a classic data modeling cycle that we would take, but the difference with COVID was that this was a really supercharged modeling cycle, so everything had to happen very quickly. Questions being asked very fast, models needed to be developed very quickly. There was potentially some very long nights to write up some code, run simulations. Decision makers and policy makers wanted to know, sometimes the drop of a hat, what's going to happen under this kind of scenario, so models would just need to be run as fast as possible. But at the same time, this is science that was going to be quite important for informing decisions, so it still needed to be as transparent as possible. And what we've tried to do with all of our modelling is write up all of the methods and make them available to the public so that anyone can go and find them on our website, have a go at building that model themselves if they want to, extending it, and it's also a great way to get some peer review. And then as more information does become available, which over the months we did start to learn a bit more about how COVID spreads and what might work at controlling it, then these models could be adapted and refined and revised. But even quite early on, in the absence of information, fortunately, mathematicians have actually got a fairly good understanding of, in quite general terms, how epidemics work and how viruses can spread. And since about the early 1900s, we've been developing mathematical models to describe this spreading behavior. And this is probably one of the simpler examples that you would use to model an epidemic. And the way it works is that you would look at your population of individuals and split them into 3 compartments. So you would say that everybody would either be susceptible to catching a virus, or they'd be infectious, or they'd be recovered. So SIR, we call these SIR models. And out of a pool of susceptible individuals, somebody can, if they encounter somebody who's infectious, they can become infected. So when we use these models, we're interested in tracking how individuals move from one compartment to the next, and how the numbers of susceptibles, infectious, and recovereds might change over time. So as an infected person goes around the population and encounters susceptible individuals, this triggers new infections, and that happens with some transmission rate. So if we were wanting to track the change in numbers of susceptibles, we would subtract the number of new infections, and then those new infections get added into a compartment for infectious individuals. But then somebody can also cease to be infectious when they recover, so they're removed from that compartment, and the number of recovered individuals will increase as more and more people recover. And that happens with some recovery rate. So this is a fairly simple version of this model, but you can add in various compartments and add in arms and legs if you want to describe kind of a more realistic epidemic. Now, as well as the transmission rate and the recovery rates, another really important parameter of an SIR model that I suspect, if not before, now everybody in this room will have heard of, is the basic reproduction number. So this is the average number of people infected by a single infectious individual in a fully susceptible population. So the R number, or R0, tells us how, whether this virus is going to result in an outbreak or whether the outbreak might die out. And the critical threshold for that is 1. So if R is more than 1, we're going to likely see an outbreak occur. If it's less than 1, then it's likely that outbreak is going to die out. So for example, an R0 equal to 3, if we started with 1 infectious individual, they would go on to, on average, infect 3 others. Each of those 3 would, on average, infect another 3 people. And by generation 4, we'd have 27 infected cases. So you can see how the bigger the R number, the faster this growth in cases is going to be, and the bigger the outbreak and the harder to control outbreak we're going to see. So I've put some example R0s for various diseases over there that you might be familiar with, and you can see how they compare to some of the newer variants for COVID. And you can see, just comparing it where the cases would be at after 5 generations, you can potentially be dealing with very different sizes of outbreaks. So for COVID early on, we didn't really have a good sense for what this R number might be. We thought it was probably around 2.5 to 3. But over the course of time, we've seen that changing as new variants emerge. So in the early stages of an epidemic, cases grow exponentially if this R number is greater than 1. But then over time, as more people are infected, the pool of susceptible individuals gets smaller and our epidemic starts to slow down. So for an infected individual, they're perhaps more likely to encounter somebody who's already had the virus and recovered than a susceptible individual, and we see a slowing down in our spread. And eventually it gets to a point where actually there's so many people who are recovered and so few susceptibles that the outbreak actually dies out. And this can happen before everybody has had the infection, so there might still be a small number of susceptible individuals left. So if we simulated a model like this is a typical output you might see. You can see susceptible individuals in blue. So over time, as more people become infected, our susceptible population starts to decrease. Infections are increasing in orange here, so the number of infecteds starts to climb, but then people start to recover or die, unfortunately. So the number of removed individuals starts to increase. And the point that we're often very interested in as mathematicians is where the peak in this infection curve occurs. And we call this a population immunity threshold, or you might have heard it called a herd immunity threshold. This marks the point where there are really enough recovereds around and too few susceptibles, which means that infected individuals are less likely to encounter somebody who's susceptible and the virus starts to die out. So it's quite a simplistic version of a model of epidemic spread, but it was really these kind of core ideas that were at the heart of a lot of the modelling we were doing over the past 18 months. And you can take these models and use them to address various policy questions in a number of different areas. I'm going to focus mainly on two today, so our non-pharmaceutical interventions, what effects those had on the spread of COVID through the New Zealand population. We were also interested in how likely it was that we could eliminate, the probability of elimination. I'll also talk a bit about border risk, which we've been looking at actually since after the March outbreak and continue to look at today. And I won't have as much time to go into contact tracing and to vaccination, but I will mention it at the end because I suspect it's probably of interest to quite a few people here. Okay, so now it's March 16 and things have really ramped up in New Zealand. And at this point, the government announced that from now on, all international arrivals returning to New Zealand would need to self-isolate for 14 days at home. So things were starting to get a bit serious. And it was around this time that Sean Hendy assembled the COVID modelling team to start to address some of these policy questions. And one of the first things that the team looked at the beginning was a bit of a comparison between two strategies or two possible strategies that were being thrown around at the time. So one of these was a suppression strategy, where we try and push down the peak of the outbreak, or a mitigation strategy, where we kind of switch control on and off in response to the number of cases. So when cases start to get serious, we can turn control on, and then when they start to decline again, we could switch it off. So to compare these scenarios, the team used actually a model that wasn't too dissimilar to this SIR model. It had a few extra compartments. So there was a compartment for people who had been exposed to the virus but weren't yet infectious. Had a compartment for people who were infectious but hadn't started showing symptoms. And then we also split that compartment for infected individuals into those that had been tested and those that hadn't been tested. And using that model, you could start to play around with just some simple scenarios. So, okay, what happens if, for example, we've got an R number for about 2.5, which is around the ballpark for where we thought COVID might be at. What happens if we turn control on around the beginning of March? And we could see the outbreak occur there. Here's our increase in cases to a peak until eventually enough people in the population have contracted the virus and recovered, and then that declines off. Because we didn't really know how effective any control measures that were going to be put in place would be, we played around with a few different effective R numbers. And you can see as your control measures become stronger and push down the R number, this has two effects. It decreases the size of the peak, so you're dealing with a smaller outbreak that's potentially going to have less impact on your healthcare system. And it also pushes the peak later, so you have a bit more time to deal with the unfolding situation. If you get measures that are strong enough, for example, these green and blue curves on the top, you can actually keep cases within the capacity of your healthcare system. But ultimately, as soon as you switch control off again, cases are going to keep going out of control and you'll still get your outbreak occurring. On the other hand, if you go for mitigation and you have this on-off switch for control, you can let cases go up until you reach your healthcare capacity, then you can put on control to push cases back down again, and so on. But you're again potentially looking at maintaining this for quite a long time until either you can develop a vaccine or some other measures to control the spread. Okay, fast forward another few days and it's March 25th. And this is when the government announced that New Zealand would be following an elimination strategy and we'd be moving to alert level 4, so we'd be going into lockdown. And I'm sure everyone has different memories of where they were at this moment. I remember standing in a supermarket feeling quite dismayed, looking at the lack of toilet roll and the lack of bread making facilities down the aisle. But at this point, we really had to switch to thinking about modelling this virus in a different way, because with an elimination strategy, we'd be dealing with very potentially small numbers of cases, and we've been interested in how likely we would be to eliminate the virus. this classic SIR model, which is deterministic, wasn't going to be useful in this case because they deal more with very large populations. So at this point, we switched to the stochastic branching process model. And this is inherently stochastic, so it deals with random events. So instead of now every infected individual going on to infect the R number, the average number of individuals, they'll go on to infect a random number. So over time, say on day T, if we're dealing with a single infected case, that case is going to go on and infect a random number of individuals. And there are a few different ingredients that tell you how many people on average that would be. If you don't like equations, you can tune out the black writing and just focus on the blue here. So how likely you are to infect other people is going to depend on the reproduction number. Rather than having one average reproduction number for everyone in the population, we allow this to vary for case to case. And that allows us to build in things like super spreading, where some people are more likely to spread the virus than others. We then have to take account of what proportion of the population are still susceptible to catching the virus, what control operations are in place at the time, and whether that case has been isolated. So we hope that if people can be identified if the virus can be detected, then they can go into case isolation, and hopefully that will reduce their chance of infecting other people. And the final ingredient in this equation is a generation time in distribution. So that tells us for somebody who's infectious, how likely are they to infect somebody else on different days since their date of infection. So you can imagine this distribution follows this kind of blue curve for somebody around day 5. That's probably when they're going to be most likely to infect somebody else. But out towards day 10, day 12, they've passed their peak infectiousness, so they're less likely to infect people at that point. And this model is stochastic, so each time you simulate it, you get a slightly different answer. So what we would do is simulate it a bunch of times, maybe a few thousand times, and look at what happens on average, but also, what's the spread of the results that we see. And it's individual based, so we can track the number of cases in individuals over time. And we can also build in some other elements that are really quite relevant for COVID as well. So asymptomatic transmission, people who aren't showing symptoms, who might be less likely to spread the virus to others than people who are symptomatic. We can also look at contact tracing, if needed, population immunity or herd immunity, and individual variation that I mentioned before. So this idea that some people are more likely to spread the virus than others. And that's why we see some of these really big, or have seen some of these really big super spreading events, like the Bluff Wedding, for example. And finally, we can also structure our populations. So I guess the simplest way of doing this is assuming that everyone in the population is quite similar, but what you can do is structure your population according to age, or look at things like access to healthcare as well. So it's really quite a versatile model, and it started out in a relatively basic form, and over the weeks and months, it kind of got added to and refined. And it's got a kind of few key assumptions. First of all, the whole model structure. So all those elements that I showed before, a lot of that has had to be assumed, but also refined as more data became available. A lot of the parameters had to be assumed early on. Where possible, we fitted those parameters using New Zealand data, but for a long time during the March outbreak, we didn't have that information, so we were having to look overseas. We were also having to make assumptions about what alert level policy would be, because at the time we were just going into alert level 4, but we were being asked questions about, okay, well, what's going to happen a few months out from now? And we might not still be at a level 4 at that point. We might have dropped down to a lower alert level. We also didn't know at that point how effective any of these alert levels were going to be, because we hadn't really seen enough cases, and there hadn't really been long enough time to look at the effects of alert levels on those case numbers. So we really had to make a few assumptions, but explore a whole range of different parameters and look at what might happen in each case. So with this model, we can compare different things, like what happens if we can isolate cases who have been tested and confirmed as having COVID, if we can isolate them very quickly, versus if that isolation is quite slow, how bad might things get? We also looked at having different alert levels in place for different durations, and played around with different levels of effectiveness as well. So as I mentioned, this R number is really quite critical to understanding how quickly this virus potentially is going to spread. And in New Zealand, because case numbers were so low, and we were still so early on in our outbreak, it wasn't really possible to get a good estimate of what the reproduction number might be here, and how far down it might be reduced by alert level 4. So what we did instead, so that we could still run model scenarios that were hopefully quite reasonable, is we looked at the international case data. So a lot of other countries back then were quite far into their outbreaks, and case numbers were quite high, which allows you to look at the growth rate in cases over time. And from that growth rate, you can get an estimate of the reproduction number. When you're not dealing with a fully susceptible population anymore, but you have some part of your population who are infected, and you have control measures in place, this is then called an effective reproduction number, so RF. And in this piece of work, we looked at a whole range of different countries that were quite far into their outbreaks. And we looked at the different control measures that they had in place, and we tried to roughly group them into the equivalent of New Zealand's alert levels 1 to 4. So it wasn't always a direct equivalent, but we kind of tried to roughly match them up. And then we looked at, for different durations of time that these policies had been in place, what effect were they having in these other countries, and could we get a range of kind of ballpark estimates for R that we could then implement in New Zealand. And you can see the results of that here. So alert level 4 in the purple circles. And there weren't any real clear trends coming through, but in general, the greatest reductions that we were seeing in REF were in countries where policies had been in place for at least about 20 days. And I guess intuitively you would think that the longer alert levels would be in place, the greater reduction in REF you would see. So on the top right here, you can see the kind of ballpark ranges of estimates that we got from this analysis, and these were the R numbers that we could plug into our stochastic branching process model to start to simulate some different scenarios for how COVID would spread through New Zealand under these different alert levels. And I've got graphs from a lot of countries, but I've just picked out a few to show you what kind of thing we were looking at. So here, over time, along the bottom axis, and effective reproduction number along the vertical axis, you can see in Italy where case numbers were really quite high. They had a really serious outbreak quite early on, particularly in the north of Italy, where they very quickly had to implement a national lockdown. And over time, you can see that the result of those lockdown measures meant that the effective reproduction number started to drop. There was a bit of a lag of about 2 weeks, which makes sense because with COVID, once you're exposed to the virus, there is a bit of a lag before you start becoming infectious. And then there's potentially another lag before you're tested, and that case is reported. So because we're dealing with reported case numbers, not actual case numbers, we usually expect to see lags like this. But ultimately, these measures were very effective, and they pushed the R number below 1. And an R number below 1 tells us the virus is going to die out. So they seem to be doing a pretty good job. Similarly, in Singapore, they actually went in with measures that were probably closer to alert level 3 than 4. And that seemed to be doing a really good job of pushing the R number down. But then if you remember what happened, I think around the 30th of March, was that a whole load of cases started to be detected in migrant worker dormitories, where it was really essentially impossible for people to socially distance because it was such high-density living. So unfortunately, despite the level 3 measures, cases took off again. They got this second wave, and they had to bring in even stronger measures, which fortunately were successful at pushing that R number down again. Okay, and then another couple of examples with slightly less stringent measures. So Sweden was one that we were all looking at with interest. They were following more of a herd immunity approach. And we looked at their policies and thought that was probably around the equivalent of New Zealand's alert level 2. And while case numbers, I guess, weren't as high as other countries were experiencing, they were still drastically higher than other Scandinavian countries. And the measures that they had in place weren't really sufficient to push R below 1. It kind of just dwindled around that 1 mark. And then in Brazil, it was very sad to watch. There wasn't really a national lockdown in Brazil at all, so they had some local cities locked down. But while it started to slightly push the R number down, but before things had really got to a place where you could safely ease restrictions, they started to reopen, lift restrictions, and the R number really never went below 1 at all. And we saw a really tragically high number of cases and deaths over there. So that's kind of how we got some ballpark estimates for R to plug into our model. But towards the end of April, we're actually at a point where in New Zealand we were seeing these cases drop off, and we finally had enough cases to be able to start to measure the R number in New Zealand. The approach that we took to do that was using our stochastic branching process model. So we simulated the model for a range of kind of plausible R numbers, looked at the prediction from the model, and then matched that back to the data to see which parameter option gave us the best fit. And what we found was that prior to alert level 4, the R number was probably up at about 1.8. But then our lockdown managed to push that down to 0.35, which compared to other countries was actually very effective. I think New South Wales had an R number around that mark. But looking globally, it was a very effective lockdown that we had here. And then towards May and into June, we'd seen these cases dwindle and drop off, and then we started to see more often these larger chunks of time where we weren't seeing any cases for a series of consecutive days. And then the question started to change from how do we eliminate to how are we going to know when this is over? If we haven't seen cases for a whole series of days, how confident can we be that that's actually because we've eliminated? And we could use our stochastic branching model to answer that question as well. So we would simulate the model, look at what proportion of simulations resulted in elimination, and then in each case look at how many days of consecutive 0 cases you had, and plot this over time. And we compared 2 different scenarios. So one was what we thought was a fairly realistic scenario, where alert levels 2 and 3 had been kind of moderately effective, but we had pretty good rates of case detection. But just to be safe, we also ran a more pessimistic scenario. So perhaps level 2 and 3 hadn't been so effective, and maybe our case detection wasn't quite as good as we thought. So you can compare those 2 scenarios just to give you a sense of confidence, I guess. And between the 2 of them, you can say probably after 2 to 3 weeks of not seeing any cases, we can be about 95% certain that we really have eliminated. And then another day to remember, 8th of June, so around this point that probably lines up with our pessimistic scenario. At this point, we could say we were 95% certain that we'd eliminated under a pessimistic scenario. The government announced that it was officially over in New Zealand, and we'd eliminated community transmission. So I think on that day, my smile was even bigger than Jacinda and Ashley's. And for us, at least, in the team, this was really a moment where we could breathe a bit of a sigh of relief, but not sit back and relax. There was a lot of work that we've been churning through and just dealing with things on a kind of daily basis. Finally, we had a chance to really write some of this stuff up and start submitting papers to journals, but also to kind of reflect on this first outbreak and think a bit about what we'd learned and what we could take from this moving forward. Now, because contact tracing in New Zealand had been so effective, we ended up with quite a nice data set with a lot of cases that were epidemiologically linked, so you could see who had infected who. So we did a bit of an analysis of the clusters that we'd seen in New Zealand and looked at how likely transmission was for different groups of people. So, for example, different age groups of people, for people who'd been a domestic case versus somebody who's been an imported case from overseas. And we found some kind of interesting trends that kind of roughly match what we were seeing overseas as well. So typically children less than 10 years were underrepresented in the data set, so not really responsible for much of the transmission. They infected fewer people, and they were less likely to be super spreaders. So this had really quite interesting implications for the potential reopening of schools, and is supported by what we were seeing overseas as well. We also found that people who were asymptomatic were less likely to transmit the virus, and people who were imported cases, as opposed to domestic, were also less likely to transmit the virus. And at this point, it became obvious as well that super spreading was really quite a key characteristic of COVID. In the data we looked at, it was about 20% of cases were contributing to about 80% of the transmission. So it really is quite a super spreadery virus. We were also able to look at this effective reproduction number again and how that changed over time for both domestic cases and imported cases. And this showed that our alert level 4 had really been very effective at pushing that R number less than 1, and also that our border measures had been effective. So we had a few border measures in place. We started off with the 14-day self-isolation, then we switched to full border closure, and then we brought in MIQ, where everybody would be taken to an MIQ facility for 14 days, tested twice before being released. And that really knocked down transmission completely. I mean, the power of hindsight is also a powerful thing. So we also reflected on, what if we'd done things a bit differently? Could we have done things a bit better? What if, for example, we'd acted a bit earlier? So what if we'd brought in alert level 4 a few days earlier? Our stochastic branching process model is really useful for that. So you can still simulate the same spread through the population, but with different timings of alert levels. So we tried a 5-day earlier alert level 4 just to see what would happen. And you can see the results here. So the real case data is in blue. The model simulation for what actually happened for the correct timings of alert level 4 and 3 is in the solid red line. And then the dashed red line shows what would have happened if we'd moved 5 days earlier. So we would have been able to push cases and deaths down a bit. Wouldn't have been a massive decrease, but the more the merrier. It would have been great to have pushed it down a bit. The logistics of moving into alert level 4 5 days earlier may have been challenging. It was quite important to put in place these essential services, make sure that was provided for so that people could lock down safely. Another thing we looked at was, okay, well, what if we'd introduced border restrictions earlier? And that's what's shown by this dotted black line. And the model suggested that if we'd brought in just the self-isolation for international arrivals at home, not in quarantine facilities, if we brought that in 5 days earlier, it probably wouldn't have made too much difference to the course of the outbreak at all. You can see that line really just sits on top of the red line. Early on, as soon as a case got into the community, because alert level 4 hadn't yet been put in place, the cases really took off. So bringing in those self-isolation restrictions, which weren't 100% effective, they were somewhat effective, wouldn't really have made much difference to the trajectory of the outbreak. And it is quite interesting to reflect on, because a lot of people have been asking, well, could we have got away with not going into lockdown at all? Could we just have relied on border restrictions, which is what was happening in Taiwan? But because it really only just takes one case to get out into the community and spark an outbreak, it really doesn't look likely that this would have been sufficient. If we'd been able to bring in MIQ earlier, then yes, that probably would have made a big effect. But again, trying to get the facilities set up and the systems in place really would have been quite logistically challenging. And then how much worse might it have been if we'd been a bit less quick to act and we'd delayed the start of alert level 4? some of these curves on the bottom give you an idea of just how much bigger an outbreak we might have experienced. So we played around with delaying alert level 4 for 5 days, for 10 days, and for 20 days. And in that worst case 20-day delay scenario, we would have potentially ended up with about 12,000 cases and 500 fatalities. So that really is quite a stark difference, and I think just goes to show the benefit of acting early, as we did in New Zealand. And the other thing we really wanted to look at was this issue of healthcare inequity in New Zealand. So we've seen what might have happened if we delayed. We could have experienced a much larger outbreak. And it's important to think about who would be most adversely affected in that situation. So as with many viruses, COVID isn't going to affect everybody the same way. We were interested in who in particular might share disproportionate health burden. So we looked at infection fatality rates. So this is out of everybody who's had the virus, what proportion of those people will die from it. And we looked at different age groups, and we grouped by ethnicity, and showed that for Māori and Pacific people, they really do suffer disproportionately if they contract the disease. So for Māori, they would have a 50% higher infection fatality rate than for non-Māori. Similarly high for Pacific peoples. So far from being a great equalizer, COVID does quite the opposite. Instead, it magnifies the inequities that already exist in our societies and in our systems. So that's really important to keep in mind when we think about even opening borders and relaxing restrictions. We also looked at risk of hospitalization, and this was with the New Zealand data. And again, we looked over different age groups and compared people with comorbidities, other underlying health conditions, with those that didn't have those. And again, for Māori and Pacific peoples, they're disproportionately at higher risk of being hospitalized if they do contract COVID. So for Māori, that was a 2.5 greater odds of hospitalization compared to non-Māori, and for Pacific peoples, 3 times greater odds. So that's really quite frightening numbers. And then we were also starting to think, is this going to come back? So I put this is quite a frightening graph. We've been enjoying so much freedom relatively over the last year and a half in New Zealand after our lockdowns. In Auckland, you've had a few more lockdowns than I had down in Christchurch. But since then, it's not been easy, but we've enjoyed relatively good freedoms. And I think this image of case numbers in New Zealand versus Taiwan really just goes to show what can happen if this does leak back in and results in a community outbreak. So back in July, throughout May, we'd hardly seen, or we hadn't seen any cases arriving at the border. So I think everyone had kind of started to relax, and then we declared elimination, and we were celebrating. But then just as we declared elimination, we suddenly started to see some cases arriving at our border again. And thankfully, the wise Susie Wiles was here to remind us that this does sound a bit scary, but actually what we're seeing isn't surprising, and it isn't a time to panic. So at this point, my colleague Audrey led this piece of work looking at, we do expect to see cases arriving at our borders again, but how many cases do we expect to see? So she looked at how many people were arriving, and prior to COVID, we would be expecting about 100,000 people arriving per week. But as the pandemic started to advance and people became a bit more nervous about travelling and countries locked down, this really dropped to about 1,000 travellers. But then around June, around the time we started to see more cases arrive, this had doubled. So this had jumped back up to about 2,500 travellers per week. The other thing that was, of course, happening was that outbreaks in other countries were getting more and more serious. The case numbers were increasing. And you can see in this bottom graph, the prevalence in other countries that people were traveling from was on the rise. So we've got more people arriving, more cases in the places they're traveling from, so we expect to be seeing more people who do test positive when they get here. And then the third thing that happened was that we also increased our testing at the borders, so we were more likely to detect people if they were positive. or if they did have COVID. So since then, we've been trying to develop these models that make use of this information, so the volume of travellers and the prevalence of COVID in the country people are travelling from, and use this to try and predict how many cases we would expect to see turning up at the border. And this has really been ongoing work. We've had to wait as more case data from New Zealand's borders has become available to kind of train up these models. But we're now getting to a really good point, and I need to acknowledge some new collaborators who weren't up on the title slide, but Thomas Lumley, who's based here at Uni of Auckland, and also Richard Arnold and Matt Parry, who've been collaborating with us on this. And ultimately, we hope to develop this model into a tool that decision makers can use to help them get a sense for how much risk from overseas travellers we expect to see. Okay, and assuming it does turn up at the border, we then need to think about how effective our border measures are for preventing those cases leaking into the community. So when somebody arrives, they'll go into managed isolation into a facility. They'll get a day 3 test. They'll then get a day 12 test. If any of those are positive, they'll go straight into quarantine until they have recovered from the virus. They'll also get daily symptom checks. Assuming both tests are negative, they're then allowed to enter the community. So there's a few interesting policy questions here. First of all, what's the risk that an arrival leaves an MIQ facility while they're still infectious? How much transmission might be occurring within facilities? Because this could mean that somebody may not have had it until they arrive, but then they've picked it up inside a facility, haven't started showing symptoms, and it's still a bit too early for them to test positive, so they're then released into the community. What's the likelihood of this happening? And of course, another way the virus might enter the community would be via a frontline border worker. So we were also interested in what happens in that kind of scenario. So first of all, the probability that infectious arrival enters the community. We wanted to look at a few different kind of border regimes. So first of all, what happens if we don't really go into quarantine at all, but we just rely on testing? So we ask everybody, before they travel, we need to see a negative pre-departure test, and then we will do another test on arrival. If both of those are negative, then you can enter the community. And you can see that without any duration of quarantine, if we're just relying on testing, we end up with a very high probability, around 30% of people being very infectious when they enter New Zealand. Alternatively, we could go with a regime of a slightly shorter stay in quarantine, around 5 days, and maybe just do a day 3 test. That does reduce the likelihood of them entering New Zealand while still infectious, but it's still quite high given that we're working on an elimination strategy and we really have a zero tolerance for any cases. If we extend that to 14 days, it gets better, but we don't really know yet how much transmission might be occurring within facilities, and if it is quite high, there's still a considerable chance, just less than 10%, of somebody entering while still infectious. But under the regime that we're actually following in New Zealand, so 14 days with a day 3 test and a day 12 test, assuming we can keep transmission within the facilities to just a moderate level, we actually have just a very low chance of somebody entering the community while infectious, round about the 1% mark. So then the question is, okay, well, how much transmission is occurring within facilities? And we came up with a kind of a good proxy for getting at this. So we looked at the positive test results that were coming out of the MIQ facilities from the day 3 and the day 12 test. And depending on the proportion of positive tests from the first test on day 3 compared to day 12, if that was a very high proportion, then we could say, okay, there's probably very little transmission occurring within the facility. Whereas if it was a lower proportion, well, we're seeing a lot of people around that day 12 mark, so we're probably getting quite high transmission occurring within facilities. And you can see over time, it really did fluctuate a bit, but it looks like we've got better, and we've put in place new systems as a few accidents have happened, and we're now at a point where we can be quite confident that transmission is relatively low. Okay, but if we did get a leak, and that was probably going to be most likely to happen from a border worker, we want to know, okay, how bad might it be? So when are we going to detect it, and how many cases might be out there when we do detect it? Well, the answer to this really depends on where we detect it. So ideally, we want to detect it early, and that would be in the frontline worker. So here, that's the seed case, would be detecting in the frontline worker. And if you look at that graph on the right, this gives an indication of how many cases we might expect to see if we're detecting in the frontline worker, that seed case, probably less than 5. But if we don't detect it until later, so further down the chain of transmission in the secondary case, we're going to potentially have a much bigger outbreak on our hands, potentially looking at around 20 cases. So we really want to detect things early. If we go back to that graph on the left now, assuming that we're doing no surveillance of borderline workers, this graph tells us that we're either probably not going to detect it, or we're probably going to detect it further down the chain, not in the frontline worker, which isn't great, because so we're probably going to have a bigger outbreak on our hands. Alternatively, if we introduce testing, so either fortnightly testing or even better, weekly testing and symptom checks, we're going to greatly increase our chance of detecting an outbreak early in a border worker while the outbreak's quite small. Okay, August 11, the anniversary. So I think this was an evening time, and many of us were kind of not really checking phones. Fortunately, Sean Hendy and Alex James were at home and were checking their phones, and they got this early evening phone call that said, okay, it's happening. We've detected a case. It's a symptomatic individual detected in South Auckland. They've probably been symptomatic for about 5 days, and we have no known connections to any frontline border workers. We need to know how many infected individuals do we expect currently in the community, and what's the probability that that infected individual has travelled outside of the area. So fortunately, Alex and Sean were able to simulate these models and start running these scenarios. Then phone call number 2 comes in about 25 minutes later. Oh, and by the way, it's in a Pacific family and a cold store worker. So at this point, we're really thinking, this has got to be a drill, right? Like, this is really the worst case scenario, that in all our pessimistic scenarios, this is it. But fortunately, Alex was able to run the model with just very short notice, and showed that, okay, we're probably dealing with something around the 29, 30 case mark. There's about a 90% chance they might have travelled outside of Auckland, and a 25% chance of them having travelled to the South Island. So a couple of hours later, that was when the rest of us were aware of what was going on, and New Zealand announced its first case in over 100 days, and you folks up here in Auckland, unfortunately, had to move into level 3 while we tried to control this second outbreak. Okay, so there was a lot of reporting to Cabinet over that time, and producing situation reports. I'll just very briefly mention 2 other pieces of work that I think were really important. Once we were seeing these community cases again, we were very interested in how effective our contact tracing system was. So in this work that was led by Alex James, she looked at effectiveness of contact tracing and showed that if you could contact trace people very quickly and you had very effective isolation, then you could potentially reduce your R number by about 60%, which is really quite a dramatic reduction. If it was a slightly less effective contact tracing system, maybe slower case isolation, it might be more like a 40% reduction. And if I was speaking to you in March, I wouldn't be able to mention this, but I've just put in one slide just to acknowledge that we've now started moving to working with vaccines. Of course, the more people in a population who are immune, the fewer pathways there are for that virus to spread through a population. We're very interested in this population immunity or herd immunity thresholds, so what proportion of the population needs to be immune before we could potentially ease restrictions and reopen borders without the need for population-wide measures. And the higher the R number, the higher this threshold has to be. So we've quite recently looked at what this might look like for New Zealand, and we've run a scenario for a very highly transmissible variant, so something like the Delta variant, if that came to New Zealand. And we showed that we'd really have to be very far through our rollout of vaccines and have reached about 97% of the population would need to be vaccinated before we could completely remove all border policies and not have the need for restrictions in place in the community. Okay, and some points that we're moving on to look at next. This is all still ongoing work, so we're interested in how sensitive PCR tests are and how this changes over different days since you were infected. We're continuing to look at the modelling of border risks, so cases arriving at the border. We're now having to update all of our quarantine and border testing models, because now that vaccinations are being rolled out, that kind of changes everything. And the other thing that changes everything are these new variants. So every single person who contracts the virus, there's a risk of that virus mutating inside them and causing a new strain. And that really does change all the parameters in the model potentially, things like the effectiveness of vaccines. So it's something that we're constantly having to look at and revise. So if you're interested in following any of this work, as I said, we're trying to be transparent as possible, and all of the papers are available on Te Pūnaha Matatini's website. Audrey Lustig and Anne Brower have also developed this open access simulator app, so you can run our stochastic branching process model yourself and play around with different interventions. And finally, none of this work happened in isolation at all, so I'd just like to extend really warm thanks to all of the collaborators across the country who've just been absolutely critical for all of this work. And I'll finish there. Thank you very much.
Thanks very much, Rachelle, for such an interesting talk. We are almost out of time, but I think we can squeeze in one very quick question. Please do make it quick, and please do make it a question.
Great. Thanks, Doc, but this is very pointed, and this is around the question around the Maori and Pacifica being 50% higher, which is very much the same across all countries spawned by what we call the uncivilized kingdom of the UK, which would be Canada, US, Australia, and South Africa as well, okay? With those populations, what is the mitigation strategy, since you know in these populations they're going to have a higher incidence of disease and bad outcomes, and also how are you going to dispel the misinformation that many people stupidly follow on Facebook rather than following experts with degrees?
Thanks for the question, yes. I don't know if I can speak to the misinformation part of that, because that was really a piece of work that's been looked at by this other subgroup. But in terms of what are some of the mitigation steps, well, I think we really need to be looking at bringing in additional measures to make sure that access to the healthcare system is equitable for everybody. And that might mean bringing in additional measures so that Māori and Pacific people have early access to healthcare, and also thinking about how we might go about prioritising, for example, vaccination, to try and, I guess, reduce this inequitable health burden that we're seeing.
Right, and I'm saying that not out of blame, because no one in this room is responsible, but in policy, racism is baked into the DNA of most of these systems. And I can say this because I was born in the UK.
Yeah, thank you.
Great, thanks very much. Unfortunately, we don't have time for any more questions, but I'm sure Rachelle is happy to stick around afterwards if you have any. So let's all thank her again for a really interesting talk. Now, I think Paul...